Hello and welcome to today's webinar. I'm so glad that you're able to join us today. My name is Bryana Gregory, pharmacist and physician liaison with Physicians Preference Pharmacy. And today we are going to discuss a couple compounds that we offer at Physicians Preference, which are addressing very relevant topics right now that I believe you're probably also seeing present in your patient population. So primarily autoimmunity and chronic inflammation. So we're going to be discussing two particular compounds. One, a lot of us are familiar with. It's been compounded for a long time. You've probably been prescribing it for a long time. That's low dose naltrexone, aka LDN. And then the second one is Amlexanox, which is one that has been added to our formulary, I think a couple of years ago now. So we have a lot more information to be presenting about this as we continue to gain clinical feedback. So I'm very excited to go through the hows and whats of these medications with you, but also to share some case studies as well, because I think that's where we really begin to see the benefits. So I always like to start out with a brief introduction of who we are at the pharmacy, but today we're going to talk about these two very important medications addressing the science of immune modulation. So at Physicians Preference Pharmacy, we are a compounding only non-sterile pharmacy. We don't offer injectables, IVs, or ophthalmic preparations. So nothing that gets injected or goes in the eye. We are completely non-sterile, meaning that what we primarily offer are the oral capsules, suspensions, sublingual tablets, which is one of our favorite dosage forms, topical and vaginal creams, and nasal sprays. And we are going to cover a few of these different formulations actually just encompassed within these two compounds. We do specialize in BHRT, so bioidentical hormones have been our bread and butter for several decades now. But as patient needs increase and expand, of course, we want to adapt to that. And much of what we are offering now is actually in the way of immune modulating compounds, and that encompasses, again, LDN and Amlexanox. Each of our preparations are always going to be free of any unnecessary dyes, binders, fillers, artificial sweeteners, lactose, parabens, which of course are hormone disruptors, especially because a lot of our patients are hormone patients. We don't want to be introducing any even inactive ingredients that are going to interfere with their therapy. We do ship to 49 states. That means shipping directly into the states, and that just excludes Alabama at this time. And all patients must have their own prescription, meaning that all prescriptions must be patient specific. Patient pays for it. We ship directly to the patient. That is one, in an effort to protect the patient. It's also in an effort to protect you from anti-kickback laws, and also in an effort to be sure that we are preserving the patient, prescriber, and pharmacy relationship. That is because we are a 503A pharmacy, non-sterile, state board regulated. We also believe that prescription drugs are commonly overprescribed, and I'm sure that you are of the like-minded if you're here and you're watching this, because we want to take more of a root cause approach. So even though whenever I do these webinars, we do, of course, talk about prescription pharmaceutical drugs, we are utilizing ones that help to bring the body back into balance. And we believe that people truly get sick either because they're deficient in something or because the body is out of balance. And so even if we can use pharmaceutical applications to help bring the body back into balance, we will be better off. The body will not be compensating as much and leaning towards chronic disease. We have a major issue of metabolic dysregulation in this country right now. It continues to worsen, and that's largely what we're going to be addressing this evening or during this webinar with these medications. Lastly, on behalf of the pharmacy, we are PCAB accredited, which means that we hold a voluntary accreditation with the Pharmacy Compounding Accreditation Board. So we have voluntary inspections or inspectors that come in and routinely inspect our facility and be sure that we're not just meeting the requirements, but we're also meeting the requirements of PCAB, which are stricter than state board requirements. And part of that, although the list of things to do to meet this accreditation is very, very long, part of that is performing on-site and third-party verified weight and potency testing of the drugs that we compound on-site. All right, so I have a lot to cover. If you know my presentations, you know I like to put a lot on the slides because You're going to get a copy of these. And yes, you can passively listen. Yes, you can take notes. But ultimately, I want you to be able to refer back to these and see some of the dosing instructions, etc. So we're going to start out with Amlexanox. And with Amlexanox, we're really going to be addressing the inflammation as well as the metabolic disease. So, do you have patients, or maybe you're a patient yourself, with chronic inflammatory conditions, autoimmune diseases, metabolic dysregulation, or other chronic conditions which are proving to be treatment refractory? When someone asks me who is a good candidate for Amlexanox, this is the patient that I'm describing. It's the I've tried everything. It's kind of a bang your head against the wall type of situation. Oftentimes, these people are very sensitive. And so, for that reason, even though they've tried a lot of different applications, they oftentimes don't respond to it, or they can't tolerate a lot of things. So, they have trouble tolerating the medications, supplements, and oftentimes are very restricted with their food lists as well. So, what is Amlexanox? Amlexanox was previously branded as a product called Apthosol many years ago. It was branded as an oral paste and applied inside the mouth on the mucosa to help address recurrent aphthous ulcers. Now, as with many other drugs, we have some very interesting regulations here in the US that don't necessarily align with other countries. So, Amlexanox being one of these, is that it's still being widely used in many other countries, primarily Japan, to treat asthma, allergic rhinitis, and conjunctivitis. We use it for many more things, which is why I'm glad that you're here to listen about this, because this is not a medication that is being widely talked about. Certainly, when we started compounding it, like I said, I think it was a couple years ago now, we were one of the only compounding pharmacies in the US that I knew of that was compounding it. Now there's other pharmacies that are doing it, offering it in different dosage strengths, etc. That being said, it's still not a widely known drug. And so this is a product that is sure to set your practice apart. So I'm glad you're here. It also shares structural similarity with drugs like cromolyn, nasal crom, and gastrocrom. So it holds that antihistaminic mast cell stabilizing benefit. One of the largest populations that we use Amlexanox in are our mast cell activation syndrome patients. So it functions as a novel anti-allergic and anti-inflammatory, and has recently been found to address a lot of other things, ranging from metabolic disease, mast cell activation, immunomodulation, and even correction of gene expression. So you can see that here, the chemical structure, the pharmacological structure, it much mimics a steroid. And that's one of the important take-home points about Amlexanox is it functions a lot like a steroid, which you may guess because you can see the type of people that it helps. However, one of the benefits of Amlexanox is it does not elicit the same side effects as a steroid, so much as that when people are stuck at high doses of steroids continually, we can utilize Amlexanox to taper them off or to bridge them off of that therapy. So who's a good candidate? Again, those with chronic inflammatory conditions, autoimmune conditions, mast cell activation syndrome, metabolic dysregulation, skin issues. So again, think mast cells in the back of the mind, not just while we're talking about Amlexanox today, but also low-dose naltrexone. The reason I will continue to emphasize mast cell overactivation, MCAS, with Amlexanox is that it has really become a complete rock star in this space. We probably had 8 to 10 products on our formulary to address mast cell activation syndrome very intentionally prior to bringing on Amlexanox, but people don't always tolerate those therapies, even if they are exceptionally clean. But Amlexanox is very well tolerated. That being said, the mast cells, which are a type of white blood cell or immune cell, one of the things that makes them very unique is that they're present in virtually every system of the body: central nervous system, the brain, the lymphatic system, the vascular system, the bladder, the GI tract, the bones, the eyes, the ears, the skin. So when we have patients that are treatment refractory, and they've tried everything, these really expensive creams from dermatologists, etc., for eczema, psoriasis, for example, and they're just not responding or they're not to complete resolution, Amlexanox really works to stabilize the functionality of the mast cells that are present in the skin, and so therefore it can help with this treatment refractory eczema and psoriasis. So those that desire weight loss, you may be hearing about Amlexanox being tailored into some of these weight loss programs. I'm going to talk to you about the dosing behind that. I don't classify it as a weight loss drug. I don't need to tell you, or I don't need to tell your colleagues that lifestyle changes are important. For some reason, this is something we have to keep emphasizing with patients, though, because people seem to want a quick fix. It's not everybody, but it kind of seems to be like 90% of people really want a quick fix. And so, I mean, they didn't get overweight over a short period of time. They're not going to lose the weight over a short period of time. This is obvious. However, anything that we talk about that may potentially address weight loss is going to be automatically benchmarked against a GLP-1. So that being said, we have to set realistic expectations with our patients about how Amlexanox can fit in. And one of the ways that Amlexanox works to support a weight loss journey, it is if that fat is inflammatory driven, the visceral fat gain is inflammatory driven, the Amlexanox works on the inflammatory component of that and promotes lipolysis. So that's how it works. It doesn't suppress appetite or anything like that, doesn't have any relation to GLPs. Think about also conditions related to T helper cell dysfunction. So Amlexanox and immune balance, this is a really important concept for us to understand. Like I said, it really does work on T helper cells, balancing the functionality of Th1, Th2, while reducing Th17 overactivity. So some symptoms of Th1 and Th2 dominance vary, but we may be looking at food sensitivities, fatigue following meals, low T3 syndrome, changes in appetite and weight fluctuations due to changes in appetite. Also skin allergies, nasal drip and mucus. So this is mast cell related. This is also histamine related too. As Amlexanox stabilizes the mast cell, it is going to decrease the amount of histamine that is released from the mast cells when they become aggravated or perceive some sort of threat in the environment in the body. Eczema, GERD, histamine intolerance, I already mentioned here. Now, again, we have Th17, Th2, Th1, Th regulatory cells. These are all really important in helping to balance the function of the immune system. And we're talking about how each of those cells impact autoimmunity, allergies, viral, bacterial infections, etc. So I said I was going to talk to you about the weight gain and the help of weight loss with Amlexanox. So of course, this overlaps with metabolic dysfunction. Obesity is directly related with metabolic dysfunction to a certain extent. There were a few studies that have been done that we're going to look at here that started out with an open label trial of using Amlexanox in those with metabolic dysfunction. The purpose of this open label trial was to ensure safety of Amlexanox when it's taken orally as such. So this particular study was done with a smaller subset of people, of course, and what they noticed is that while dosing Amlexanox 25 milligrams 3 times a day, and just to give you an idea, remember these are preliminary or open label trial studies, fast forward to today, what we offer, we have a 10 milligram, a 20 milligram, a 40 milligram, and a 60 milligram. I'm going to show you why we choose one dose over another. The one I want you to keep in your head is 40 milligrams of Amlexanox. Don't really recommend messing around with anything else, of course, when it comes to exceptions. So this is a fairly low dose, and it's 25 milligrams prior to each meal. What they saw is that there was a measurable reduction in fasting blood glucose. We still see this benefit today. Fasting insulin resistance was improved, and they also saw decreased hepatic glucose production. Now, we know that there's an inflammatory link between obesity and type 2 diabetes. Following that open label trial, they then bumped it up to 50 milligrams 3 times a day for proof of concept from that open label. So they really increased the dose. Well, they doubled the dose 3 times a day. And they saw a reduction in weight, insulin resistance, fatty liver, and inflammation. These people that were studied actually also had non-alcoholic fatty liver disease. There was a double-blind, placebo-controlled study of 42 obese patients. So here it says here, so non-alcoholic fatty liver, and also they saw a reduction in hemoglobin A1C. This is something, of course, that we monitor in all of our patients. And so we do see marked reduction in the hemoglobin A1C. Since it's something that we're always testing, it's pretty easy to see if there is improvement there. So let's cover some of the benefits and uses of Amlexanox. So we want to look at the mechanisms of action, of course, to understand how we're getting certain benefits. So big star bolded right here, mast cell stabilizer. It reduces the release of histamine and leukotriene mediators from the mast cells, neutrophils, and monocytes. We are seeing a lot of increased diagnoses of cancer. The reason we would use Amlexanox in those people is because it inhibits Th17 cells, but not Th1. Promotes longevity and inflammation. It does that by cellular autophagy via the mTOR pathway. One drug that I have commonly discussed is rapamycin, and that is a very well-known mTOR inhibitor. So there are a couple different mTOR pathways, mTOR1, mTOR2, they do different things. However, when we can inhibit the function of that pathway or decrease the function of that pathway, we can promote cellular autophagy, we can get rid of those zombie cells, we can induce cellular apoptosis. We know that the mitochondrial function, cellular autophagy are major key regulators to dictating biological age and longevity, as well as managing chronic inflammation, and that's how Amlexanox plays a role here. We also see it as an immune modulator because it modulates macrophages, balances Th1, Th2, and regulates T cell function, which we looked at on the previous slide. Also utilized in neurodegeneration. So as you can see here, a commonality between all of these MOAs is inflammation. It decreases inflammation and oxidative stress. It also can work in erectile dysfunction. The reason why is it can help to maintain an erection due to PDE5 inhibition, which we know is a major mechanism of action of common drugs on the market used for erectile dysfunction, and then works as an antifibrotic. So remember, in that previous study looking at metabolic dysfunction, we saw that those patients had non-alcoholic fatty liver disease, which we're seeing more of today. Amlexanox binds to fibroblast growth factor, which is useful in some of these atherosclerotic diseases, cirrhosis, non-alcoholic fatty liver, and then conditions with fibrotic tissues and other diseases. Also, metabolic disease. We talked about this one already. I mentioned at the beginning of the webinar that one of the reasons why it works for obesity is because if obesity is largely driven by Th17 inflammation, visceral fat tissue may become resistant to lipolysis over time, which can lead to obesity, insulin resistance, metabolic syndrome. But because Amlexanox helps to lower the Th17 inflammation, it helps to sensitize the fat cells, bringing them back to lipolysis, leading to fatty acid oxidation and reduction in fat volume. And I think that is such a cool mechanism of action. Vasodilation. So it's not intended to be used as a blood pressure medication. However, one of the things that we see is that people usually report that their blood pressure regulates. So it's not strictly just producing a reduction in blood pressure, but I think part of where this is coming from is one, it's anti-inflammatory, and two, it's a mast cell stabilizer, which means it's decreasing the release of histamine. Histamine has a direct effect on the vasculature and the endothelial lining of the vessels, which will cause some vasoconstriction. And so we want to be sure that we are addressing that, the vasoconstriction and vasodilation, and controlling that with Amlexanox. It's kind of more like an added benefit of using it because many people with metabolic dysfunction also have blood pressure issues. We saw its use in non-alcoholic fatty liver. I talked about psoriasis, the same would go with eczema. So we're always looking for that Th1, Th2 cell balance. Now, what about genetics? There's some interesting information showing that Amlexanox may correct gene expression in conditions like cystic fibrosis because it addresses that nonsense gene mutation that leads to that misfunctioning chloride channel. Asthma, allergies, and bronchodilation, other than MCAS, this is, I would say, the other top use for this drug. Remember, it's used widely in Japan for these bronchospasm and respiratory issues. It does inhibit phosphodiesterase, CAMP, which leads to bronchodilation and reduction of inflammation. This is why I take Amlexanox. I am a transplant from California to Texas. And like most people that move to Texas from elsewhere, they develop allergies, bronchospasms, some sort of respiratory inflammatory issues. The same would go for myself. There's a lot of things that I've had to do using Amlexanox in conjunction with that. So I will talk more a little bit about my personal dosing of what I use for Amlexanox, but I do think that it's important to keep in mind when you're writing the prescriptions for Amlexanox to give patients some liberty in how they dose it. It's not an as-needed medication. It can be used like that, but if someone only needs it on a PRN basis, there's probably other things that they can do to help address those symptoms, histamine, lifestyle, food choices. Okay. But all that to say, most of the time year round, people can get away with a consistent dose. But when, let's say that they live in Texas, they live in a place like Houston, like I do, or hurricane season, like it's pouring outside right now, you may be able to hear the storm. And it's going to bring a lot of things in. And so with that, there are environmental changes. So tomorrow I might need to take 2 Amlexanox instead of 1. And so with your patients, it's going to be the same. They may not be on 1 capsule every single day, 365 days a year. So I do recommend writing it 1 to 2, 1 to 3 capsules. We'll talk about the dosing strategies, but again, giving them some liberty is extremely helpful for them. That way they don't run out of the refills early either. All right, long haul syndrome, mast cell activation. So post-COVID, we see a lot of people that are still suffering with long haul issues, meaning that they have had COVID infection. They're still presenting as if they have it almost, but it's been months or years later. Okay, so one of the reasons why this happens is because in the brain, in the central nervous system, they are having mast cell dysregulation, mast cell overactivation, and that inflammation leads to excessive brain fog, decreases the amount of oxygen that can be delivered around the body. So Amlexanox can help to improve that first by decreasing mast cell overactivation, but also addressing histamine. Histamine is something I take very seriously with my patients. I see a lot of patients that have histamine intolerance and they have no idea what that means, and their doctor isn't talking to them about it either. But a lot of them do present with mast cell overactivation, which means that subsequently they're going to have issues with histamine. So there's a lot that we can do with foods, lifestyle changes, hormone management, decreasing stress as well to address histamine in a natural way. What we cannot address with lifestyle or foods, we can come in on the back end with and address with Amlexanox. All right, let's talk about clinical pearls. So as I mentioned, we have 1, 2, 3, 4 different doses that are available. We initially started with a 40 milligram capsule as the only one that was available. Then we heard some information that some people were wanting 60 milligrams sustained release. The only reason, to my knowledge, that this was originally created, there were other pharmacies that were compounding it like this, and I can't really remember if it was the pharmacist. I think it was a pharmacist that came up with the SR formulation in an effort to improve compliance, which I get that, of course. They're taking higher doses, lesser times per day. However, what I find is that many people on Amlexanox are very desperate and they're just going to take it. They're going to take it the times a day that they need it. The other thing is, yes, it's an SR formulation, so it is going to be easier on the stomach. But if there is any particular side effect with Amlexanox, it's some mild nausea. I would classify it as mild queasiness because when I have taken this on a completely empty stomach, I have experienced that. That being said, start with 40 milligrams in, I would say, probably 95% of your patients. And remember, we're using Amlexanox in very sensitive patients. And so many sensitive patients, very sensitive patients, can handle the 40 milligrams once a day. They may need it up to 2 or 3 times a day. They should be splitting these doses up and not taking multiple capsules at once. I probably have, I would say, less than 10 patients, maybe 20, that are on the 10 or 20 milligrams. What I prefer also for cost reasons is that if the person can purchase a 40 milligram capsule, they're very sensitive, but they still don't tolerate the full 40 and they're nervous about it, then they can open up the capsule and they can try a little bit, basically just to get their body used to it. If they're going to respond to it, or if I should say, if they're going to react to it, they're going to know right away. They're not going to get a therapeutic response, of course, because they're not maxed out at the therapeutic dose. However, that makes a lot of people feel more comfortable. The only other ingredient inside of these Amlexanox capsules is baking soda. Baking soda is one of the most gentle fillers that can be used for those that have mast cell overactivation, because it is very inert when it comes to its response with the mast cells. So again, 40 milligrams once a day, up to twice a day is where most people get their full benefit. I take one 40 milligram capsule of Amlexanox every day for probably 350 days out of the year. And the other couple weeks, I may rely on one capsule twice daily. In an unlikely event, I may need one 3 times per day. Where you start to need it up to 4 times per day is where you're weaning people off of high dose steroids or your long haulers. Your long haulers are more likely to need more of these capsules per day. And again, please be sure that they are dosed in divided doses. And again, queasiness is going to be the most prominent side effect, if any. All right, so let's talk about low-dose naltrexone, LDN. Now, low-dose naltrexone is a low-dose version of something that is commercially available. You're probably already prescribing it, and if you're not, it is very simple to begin integrating. It is very safe. We love safe and we love minimal side effects. So here we're going to be talking about autoimmunity as well as inflammation. So we're going to be talking about low-dose naltrexone, which I'll refer to as LDN from here on out. But for us to understand what the low dose of naltrexone is, we have to understand what naltrexone is, which is just the normal dose of naltrexone. So this is a commercially available manufactured drug, and naltrexone is FDA approved for the treatment of alcohol and opioid dependence. So education time for patients, let them know on the front end when they go Googling their new medication that you're not trying to wean them off of alcohol opioids when they have no history of alcohol or opioid addiction. So just tell them it's only a compounded product with its low dose naltrexone, and so it's being used for something very different. This is a conversation we have with many repurposed drugs when patients get their prescriptions for repurposed drugs for the first time, because what is commercially available, the dose or the dosing frequency is much different than what we're recommending. And so therefore we get 2 completely different responses to address 2 completely different issues. Naltrexone, not a compounded product, again, commercially available. Typical dosing for this purpose for opioid alcohol dependence is about 50 milligrams to 300 milligrams per day. And just keep in mind, this is about 10 to 60 times the dose that we're going to be discussing. So much, much higher, again, which is why we get a different response. So same chemical compound, just a lower dose. LDN is only available at compounding pharmacies. LDN, low dose, is considered to be less than 25. Remember, when we looked at regular dosing of naltrexone, it's between 50 and 300. Here we're talking about less than 25. I do not think I have any patients that are on more than 9 milligrams of low-dose naltrexone. So even 25, even though that's the definition or the cutoff for low dose, I've never seen anyone at 25 milligrams for inflammatory or autoimmune conditions. I have talked to some providers that do that, but I have never dispensed anything that high. So it's also applicable for, again, autoimmunity, inflammation. Those are kind of our poster child patients for LDN, and it is not used for the same indications as naltrexone. So LDN has a really interesting history. As a pharmacist, I love learning about the history and the sources and where these drugs initially came from, why they were initially used, and it tells us a lot about the mechanisms of action. So back in 2003, an issue of the New England Journal of Medicine provided evidence that indicates that opioids alter the development, differentiation, and function of immune cells, and that both innate and adaptive systems are affected, suggesting opioid-induced immune modulation. So we're talking about an opioid drug. We know that naltrexone is used to help wean people off of opioids. So that is probably already telling you, if you didn't already know, that LDN binds to opioid or opioid-like receptors. Now, bone marrow progenitor cells macrophages, natural killer cells, T cells, B cells, they're all involved in this immune modulation. So the ID of opioid-related receptors on immune cells makes it even more likely that opioids have a direct effect on the immune system. So we are extrapolating there's been a lot of research in between this, but we're extrapolating that if opioid drugs that bind to opioid receptors have an effect on the immune system and pain and nerve conduction, then it's very likely that this other drug, LDN, which binds at those receptors, is going to have a similar effect, but we can get away with a much safer drug at much lower doses without the repercussions and side effects, with still pain control, nerve control, and mood modulation and immune modulation and inflammation modulation. All right, so what's the connection? LDN, opioids, endorphins. There's a lot of overlap that is spoken about here when we're talking about the uses of LDN. So our endogenous opioids, which are called enkephalins, help to regulate pain. Endorphins help to regulate mood, of course. These are going to be affected by LDN. The body's own endorphin, which is metenkephalin, is an opioid growth factor, has a similar chemical structure to naltrexone, which is why it likes to bind there. The opioid-like opioid growth factor receptor, it's found in the brain, spinal cord, stomach, small intestines, and in the immune cells. So this is why LDN is helpful in the central nervous system, in the stomach, in the small intestines, and in the immune cells. It binds by blocking that OGF receptor, increasing the enkephalin and endorphin production and opioid receptor sensitivity. If you have prescribed LDN already, then you know that one of the potential side effects of LDN is vivid dreams, and this is why. So for many years, we were advised to recommend, to prescribe, and to advise the patient to take LDN at night before bedtime because we thought that it increased efficacy. And it is highly efficacious when dosed at that time. The reason why, and the reason why people may get vivid dreams, if that is a side effect that they experience, is because while we are dreaming, those endorphins are more active, contributing to the vividness of any given dream, whether or not someone is on LDN. And so that's how we know that there is this overlap or efficacy with endorphin production for those people that take LDN. Increased levels and activity of endorphins and enkephalins also regulate immune cell production, and LDN works by increasing the body's release again of those endorphins. So this can decrease the immune system's inflammatory response on its own healthy tissues, AKA, what is that? Autoimmunity. All right, so we have several opportunities for LDN. Ever since I was in pharmacy school, working in pharmacies, became a pharmacist, I have dispensed LDN. So it's been around for a very long time. And it's a drug that I follow quite closely, and I continue to see the opportunities or the indications for LDN. That list keeps getting longer and longer and longer, again, because it's working on immune cells and it's working on many systems within the body. So that's why it casts this net so broadly. We anticipate that about 75 million people in the US suffer from autoimmune conditions and or chronic pain. That encompasses more than 100 different autoimmune diseases. Inflammation is obviously ramping up. And then we can also use LDN to wean people off of pain meds, muscle relaxers, antidepressants, and anti-anxiety medications. This, of course, is done with your very close oversight. In fact, one of the populations that we have to be careful with are those that are on around-the-clock pain meds, particularly cancer patients or people that are on high doses of opioids. If they are to be on those doses around the clock, LDN will interfere because it it competes for the receptor site of opioids, right? Because we know that's largely how it works. So we either need to be spacing it out or avoiding LDN in patients that are on around the clock pain control. However, that being said, because it is competitive, it's something that we can potentially use to wean them off of that. So if you're a table person, here is a list of common applications for LDN. So you'll get a copy of this, but again, we're talking about autoimmunity, really common ones. One of the most common uses, Hashimoto's. Sjogren's is very common. Also Lyme disease. In the GI tract, I'd say Crohn's and ulcerative colitis, most common. Dermatologically, eczema and psoriasis. Neurologically, MS, fibromyalgia, And then others, higher doses of LDN are necessary to help people achieve weight loss. Part of that is with the ramping up of endorphin production, and then very much so for pain and depression. So how does it work? We've talked a little bit about the MOA, but this is more from an application standpoint. So what does it do? It provides short-term opioid receptor blockade. That's kind of the MOA. It does that for about 4 to 6 hours. So think about if you need to space it out from pain meds, you want to have that 4 to 6 hour rule. It again increases endorphin release, providing pain relief and healing, modulates the immune response. It does this by regulating lymphocytes, down-regulating cytokines, and again, reducing mast cell activity. So LDN is one of the OGs with reducing mast cell activity. So we still use it as a staple, but I'm going to show you here in a few minutes what it looks like to use Amlexanox and LDN together. LDN reduces inflammation, inhibits overexpression of the toll-like receptors. That's partially why it's helpful in Crohn's and psoriasis. It helps to decrease release of pro-inflammatory cytokines and also work on T lymphocytes. It can provide neuroprotection through glial cell activation in the central nervous system, of course. And then the evidence continues to grow in the space of it supporting cancer because it promotes T cells, natural killer cells, and upregulates genes responsible for apoptosis. All right, again, if you are a chart person or a table person, here is a lot of what I just said. So you'll get a copy of that. We get healing, we get decrease in inflammation, we get downregulation of Th17. So there are some overlaps with Amlexanox as well. So this is a pretty small table for you to be able to see, but where you would find this would be on the IMA Health website. So what used to previously be FLCCC, the Frontline COVID Critical Care Alliance, has now been rebranded as of the beginning this year as the Independent Medical Alliance, which is now IMA. This chart comes from a phenomenal paper that is, I think, about 260 pages long now called Cancer Care. Cancer Care is very easy to find on the IMA Health website, but the website is IMA, like Igloo Mary Apple, imahealth.org. And you can even Google cancer care, imahealth.org, and you'll find this. And basically what this paper is it is reviewing the anti-cancer benefits of repurposed drugs, which we do consider LDN to be a repurposed drug because we keep finding out new things it can be purposed for, as well as nutraceuticals. Now, this particular chart shows us the list top to bottom of certain repurposed items, and then left to right, the benefits that we may see. So increased apoptosis, increased autophagy, increased immunity, decreased cancer stem cell production, for example. When we have pluses, we know that it has application at any one of these particular indications that we talked about. Now, probably difficult to see, but LDN works all the way across the board with the exception of decreasing glucose and glutamine. So it is going to have, in cancer patients, applications for balancing out immunity, helping with inflammation, decreasing cancer stem cell activity. I know a lot of people, I've never recommended this, and I'm not really sure what the dose is. I imagine it probably is around the standard 4.5 milligrams a day that we use. I should ask this the next time I talk to someone that is doing this, but I know a lot of providers who are self-dosing, they're dosing themselves with low-dose naltrexone as a preventive for cancer, which is a very interesting concept. I'm not sure there's literature on that, but what we do see literature in is how low-dose naltrexone may affect some of the pathophysiology that is present in those people that have been diagnosed with cancer. All right. So let's talk about some of our compounded formulations for low-dose naltrexone. So we have a few different ones. We have it present in oral capsules, sublingual tablets, also topical creams. So if you go to pretty much any compounding pharmacy, they're going to offer hormones. They're likely going to offer LDN. Now, you do want someone that has experience dosing and titrating LDN because although it's very easy to implement, if you don't know how to titrate it or what to look for, it can be a little bit tricky. But the doses that we have available on our formulary for capsules range from 0.1 milligrams to 9 milligrams. By the way, you can find all of our formulations on our website at physicianspreferencerx.com. There's a drug catalog on there under the prescribers, nested under the prescribers section. But I've just given you bookends here. So from 0.1 to 9 milligrams, sublingual tablets, which is going to have a better absorption than the capsules, we have from 0.5 to 4.5, and then the topical cream from 2 mg to 30 mg per ml. Now, usually people will fall somewhere in the middle for dosing on that of the dosing ranges. And then we also have a proprietary formulation, which is called Physician's Preference Eczema and Psoriasis Support Cream. It does have ivermectin, LDN, zinc pyrithione, hydrocortisone in it, and it can be made hydrocortisone free, especially if you're giving it to kiddos, which we use this a lot in kiddos because they tend to have a lot of eczema. And then also if someone is using it consistently, you don't want them to have that much hydrocortisone, or I should say repeatedly or routinely consistently, then you can make it or prescribe it hydrocortisone free. So just a few before after pictures. These are always important with our eczema and psoriasis support cream. We had a young girl that obviously was having some skin issues here, by her described as eczema. I think there was a little bit more going on there. Probably some candida in that area, and some of these skin folds and other things like that. But after just 7 days on the cream, I mean, if anything, it's really dramatic color improvement, which is quite nice here in the crease of her neck. Success in ulcerative colitis with oral LDN. This is working someone up to 4.5 milligrams daily. So ulcerative colitis is obviously an inflammatory condition affecting the colon and the rectum, but we like to always tell people to give low-dose naltrexone a good 6-month trial to say, yay, nay, it's working, it's not. And there will be different phases of healing and of noticeable benefits. Usually within the first few days, people are going to notice the reduction of inflammation in the joints and just overall decrease of inflammation, as someone might describe it, like what they feel in their body. But if they have an internal issue going on over weeks and months, they're going to have cellular repair. They're going to have reduction of inflammation at a cellular level. Obviously, you can't feel all the improvements in ulcerative colitis, but during the first few days, weeks, we expect people to have a very noticeable impact of the reduction of inflammation when on LDN. So let's do the side by side. Whenever we have a commercially available drug and a compound, I do like to do this just so that you know what is the difference and why may we choose one versus the other. So again, common uses for naltrexone: alcohol and drug dependence. For LDN, think inflammation, autoimmunity, and derm. For typical dosing of naltrexone, between 50 and 300 for LDN. Most people, like 99% of people, fall within this dosing range, 1.5 to 4.5 milligrams per day. What about titration? So with naltrexone, you want to hit it hard and hit it with high dose to address the alcohol and drug dependence. So there's not a titration there, but for LDN, yes, I'm going to go over the titration. For the age limit, really, we only worry about that with LDN, and it's actually weight-based. So for anybody over 18 pounds, they can take the LDN, which is why we use it in a lot of kiddos. Side effects for naltrexone: liver injury at high doses, headaches and nausea. LDN, GI discomfort, which is always transient for folks, and then these vivid dreams. Now, I mentioned before that I was taught, most of us were taught, that when initiating low-dose naltrexone, it should be given in the evening time. That really can contribute to vivid dreams. So if your patient already experiences vivid dreams and nightmares, and that's a concern for them, please don't dose the LDN at night. Please give it to them in the morning. People that dose it in the morning should not have any issues with vivid dreams. If they do, probably need to lower the dose. Now, naltrexone does cross the placenta and into breast milk, so that's a consideration. A common question I get is, can I use it in pregnancy? And this is a risk versus benefit answer. I don't have a good answer because we don't have a bunch of pregnant ladies hopping in line for LDN studies while they're pregnant. But are we talking about a very major autoimmune condition that can put the baby at risk? Then it's probably good to have them on LDN, but that is certainly a patient individual conversation. Now, very important when it comes to titrating this. So the most common titration schedule is prescribing a patient 1.5 milligrams of LDN in a capsule form, because it's going to be the easiest for them to take. It's very low chance of user error, and it's the most cost-effective dosage form. So they take one of the 1.5 milligram capsules And I'm going to have this written out on the next slide, but I want to talk about the titration and when to back down. So starting at 1.5 milligrams of naltrexone daily for 10 days, they're going to take 1 capsule. For the next 10 days, they'll take 2 capsules. For the next 10 days, they'll take 3 capsules. At the end of month 1, it's a beautiful finish line for have titrated up to 4.5 milligrams of LDN daily. So then they can go ahead and fill a 4.5 milligram prescription for low dose naltrexone going forward, assuming that that is their total intended daily dose and they tolerate it well. Let's say you got a patient that works up to 3 capsules of LDN, so the 4.5 milligram total daily dose during that last 10 days of the month or so, and maybe they get 2 or 3 days into that and they are just not tolerating it well. They have really bad GI discomfort or their dreams are really vivid, something else is going on. It would be good to back them down to the previously tolerated dose, which would be 3 milligrams daily, and do that for 10 days, which is what I've listed down here. So try reducing that dose for 10 days and then re-challenging again. LDN is an immunomodulator, so we do want to push the dose up to the max tolerated dose while we're also getting efficacy for whatever it is that we're trying to treat. So we do want to push the envelope. We're not just trying to go sky high with the dose, but we need to go as high as we can for symptom resolution that is also tolerated. Now, here is written out what I just said. Most patients tolerate 1.5 milligrams to start just beautifully. It is very common to titrate LDN up every 7 days, and I think that's completely fine. Quite frankly, from a pharmacist perspective, it just makes the label, the instructions on the label really long, and which makes it really small, so it makes it hard to read. It's a little bit more complex for patients than if they have to hold the dose and they do it for 10 days. They get confused because they go up every 7 days. Why are they holding it for 10 days? There's not a hard and fast way to do this, but that's why I like 10 days. It just gives them a little bit more acclimation during the titration period. And then, of course, as soon as we can consolidate all of that dose into 1 capsule, it's going to save your patients money. Please let them know they may get worse before they get better. It's okay. We are probably going to shake things up when we're balancing the immune system. What we expect time to improvement wise is first improvement with pain and inflammation after first few doses in the first days or weeks. For those people that have long COVID, Lyme disease, really bad issues with brain fog, also thyroid, Hashimoto's issues, we really want them to give it a good 6-month trial, and they may need that. I mean, they're going to get improvement along the way, obviously, but at 6 months, we want to be able to make a good determination if they're getting the resolution that they need. Same for immune stabilization. So please let your patients know, for one, they have to be consistent with it. I don't want to fill a prescription for a patient that's not going to be consistent with it because it's going to be a waste of their money. If they take it every 4 days, they're never going to get to where they need to be. And if they titrate all the way up and then they stop, they will backslide and they will need to titrate up again. And I don't like seeing that for these people because they've got to be consistent. They may expect a lifelong commitment to LDN. They might not, but they do need to at least be at their max dose for 6 months to determine if it's working. So a couple considerations is if your patient's on opioid meds or tramadol, then remember the LDN may compete for that, so it needs to be spaced out. If your patient is on short-term opioid therapy, then you can leave that 4 to 6 hour gap between dosing those meds and dosing LDN. If they're on around-the-clock opioids, then or high-dose opioids, no LDN. For patients that have had organ transplants, or taking immunosuppressant medications, it may lessen the efficacy of the anti-rejection meds. All right, I have a few case studies I want to share with you. I'm excited about these. So these two ladies are so impressive, the benefits that they have had with both actually LDN and Amlexanox. So I want to preface it with this. Amlexanox, although it's been around for a long time, to compounding pharmacies, it's relatively the newer kid on the block, meaning that when patients come to us and they start on Amlexanox, they're usually already on LDN because LDN's been around a long time, which gives us a very interesting insight to this subset of individuals that are good candidates for Amlexanox but have already been on LDN and have had a lot of improvement on LDN alone. But I actually recently published an article, co-published an article that looks at the use of LDN and Amlexanox in folks. And even though that wasn't the main idea, we also presented some information recently looking at that. Do we think that there's some synergistic activity here potentially? When I ran records in my pharmacy system, what I found, and I'm not saying I recommend this, but I think I can get behind the why for sure, especially when we're trying to address polypharmacy. What I found is that a lot of patients that have been on LDN with us for years, once they started Amlexanox, they then discontinued the LDN. So there's certainly some overlaps that are happening there. This particular young lady, just 37 years old, had a clinical history of joint pain, fevers, butterfly rash that came up 2 or 3 times a year, those EBV flares. And LDN was initiated to control those flares. Really helped her a lot. She started having spontaneous food reactions, was quote unquote allergic to everything. This is a common quote from a lot of people that come up with mast cell overactivation. And she was relying on at least 50 milligrams of Benadryl for every flare. We then started her on Amlexanox 40 milligrams a day, which was added in for the uncontrolled food allergy reactions. And she did begin to limit gluten in her diet. So this is not all due to Amlexanox addition. It's also due to lifestyle modifications. But she began having resolution of joint pain, the butterfly rash, food allergy reactions. At the time I wrote this up, she had had 40 pounds of weight loss. I actually touched base with her today. She has lost 96 pounds. And I love for her that it is consistent, attainable, and she's done it in a way that we do not expect her to yo-yo. So she has incorporated Amlexanox in her regimen to also help with weight loss. But I mean, look at this butterfly rash. It looks so painful. This is her side, these rashes she was having, and she's just lighting up after being on Amlexanox and the rest of her changes that she made lifestyle wise. Her skin is clearer, obviously. She just looks a lot happier. So one thing that she said that I thought was interesting, she said it to me, is by starting on Amlexanox, it completely cleared up her skin and it gave her the confidence to get on a weight loss journey. All right, so this young lady, 60 years old, clinical history of asthma, food allergies, hypothyroidism, sex hormone dysregulation, edema, poor digestion, candidiasis, Lyme disease, Babesia bartonella, blood biofilms, POTS, and MCAS. A lot going on. She, when I first met her, would have typical Herx reactions to most meds and supplements, not just antibiotics. And yes, this is wordy. I just think it's important to explain what these people are going through. She would have puffy eyes, swollen hands, intense redness in the ears, resembling a sunburn, severe itching affecting the mouth, nose, face, torso, swollen tongue, darkened lips. She described a sensation like her calves were about to pop and a spongy feeling on her scalp, itching, headache, and dry heaving. Physical activity or any effort for lymphatic mobilization was not received well, even if it was very gentle, like baths or dry brushing, and that would leave her bedridden. That alone would leave her bedridden 1 to 2 days, requiring extended recovery. At intervention, meaning when kind of we started intervening on her plan, she was on oral antihistamines, she was dependent on inhaled steroids. On some days, her medication regimen included a total daily dose of ketotifen 4 milligrams, 180 milligrams of diphenhydramine, 16 milligrams of chlorpheniramine, 1,800 milligrams of ibuprofen. That was just to get through the day. She was also on 9 milligrams of LDN already, nebulized albuterol, the inhaler, pulse EMF therapy, IV ozone, glutathione, blood irradiation, Myers cocktails several times per week, and her regimen included 81 medications and supplements in total. When I first intercepted this patient, I said, I need you to send me a full list. I do that often, and often it is very large. It's not usually 81. Usually the large ones are around 40 or 50 different products. 81 is a lot. And unfortunately, what I was trying to do for her was med rec and see if there was duplicates, and there were not. There's nothing I could do. There was no duplications I could get rid of out of her regimen. However, I said, well, why don't we go ahead and try Amlexanox, because I like to use that as a polypharmacy aid. So in January of 2024, she started just 40 milligrams a day. By the third day of Amlexanox, she required only albuterol inhaler, no longer needing the nebulized albuterol. Within 7 days, she reported marked reduction of airway mucus. After 60 days of just once taking 40 milligrams once a day. So after 2 months, she notes improved breathing, significantly reduced symptoms of MCAS, eliminating her need for inhaled and nebulized albuterol. Again, we see a major reduction in polypharmacy here in just 2 months following the addition of Amlexanox 40 milligrams in her daily routine. She reduced her medication and supplementation regimen from 81 to 17 agents. So for a pharmacist, that's like, yes, that is a huge win. We love lopping off these things that just are not serving patients. So we do think patients should be on what they need. However, I think this is a classic example of throwing a lot of spaghetti at the wall, and a lot of things truthfully were not helping her. This young lady I just spoke about, that we achieved some good reduction in polypharmacy with her. This is our co-publication. So myself with Dr. Yusuf Salibi, and we looked at a handful of case studies actually that looks at how Amlexanox is a promising alternative to steroid and antihistamine dependence in patients. All right, so I want to thank you guys so much for sticking with me. It was about a whole hour of just me talking. So as far as getting prescriptions to us, you can always call us and learn more about the ins and outs of that. But here is that information for you. We can accept prescriptions by fax, e-scribe, or by phone. Our website is here. Again, our drug formulary is present on that. Again, I'm one of the pharmacists there, but I'm also the physician liaison, which is why I do these webinars. So I do maintain the relationships with all of you across the US. And please do feel free if you want to hit me with questions about specific patients, or if you just want to call the pharmacy and talk it through, we can also do that. If you are interested, I will be discussing this information in person in DC, Washington, DC, coming up next month, in just about a month, actually. You can join the AAPS conference either virtually or live, depending on where you're at. That is the Association of American Physicians and Surgeons, and this is a fantastic, independent, very active community of physicians who are like-minded, and I'm very excited to be invited back there to speak to them. So I'm going to go ahead and stop sharing my screen now. And I know we just have a couple minutes for questions, but if anyone would like to send in some questions or put them in the chat, I'm more than happy to take those as well. As far as pricing, because this is always a question we get, when we're looking at the 40 milligram capsules of Amlexanox, the price for 30 of those is $59 for 30 capsules of 40 milligrams. And the price for 90 capsules of the 40 milligram Amlexanox is $129. So most people are going to get away with a price in between that particular dosage range. All right. So it doesn't look like we have any questions. We got some comments. Thank you guys. All I can say to you is I hope that you found this information valuable for sure. I guarantee you, I do spend a lot of time in physicians' offices everywhere. And so one of my goals, other than trying to keep our patients as healthy and empowered as possible, is to do the same for you as prescribers and to help you differentiate your practice. Because if you're growing, you're learning, I'm growing, I'm learning, the patients are getting better. So please do not overlook these repurposed drugs. Amlexanox and definitely LDN are products that you want to incorporate. So we will go ahead and see you guys next time. If you have any questions, feel free to write me in, and I hope you guys take care and stay well. God bless you.